A 70 year a 71 year a 70-year-old woman with 20-year history of hyperlipidemia and hypertension is brought to the emergency department 30 minutes after an episode of facial drooping and difficulty speaking. His symptoms lasted his symptoms lasted or what is okay. Her symptom lasted 30 minutes after he has been resolved. Medications include lisinopril, pravastatin. He has smoked one pack of cigarettes for over 40 years. Vital signs are within normal. Physical examination, including neurological examination, shows no abnormality and ECG sinus rhythm at 80 minutes. Non-conscious CT scan shows no evidence of hemorrhage or infarct. Which of the following is the most appropriate to administer at this time?
Ready?
Yes.
So it's aspirin. TIA is defined as transient episode of neurologic dysfunction lasting less than 24 hours caused by focal brain, spinal cord, or retinal ischemia without infarction. This patient has developed focal neurologic deficit that resolved after 30 minutes, qualifying at TIA. TIA can be induced by either embolus arising from proximal side or from temporary decreased blood flow to a watershed area in the brain. A low flow TIA typically lasts minutes, while an embolic can last longer. As in this case, an embolic ischemic stroke involves an event in which a clot breaks off and travels to the brain, occluding blood flow within the cerebral artery. Emboli most commonly originate from proximal vessels such as internal carotid artery or from atrial thrombus. If the embolus successfully undergoes physiologic thrombolysis, blood flow is restored into the affected area and reverses the clinical symptoms. After the TIA, measures for prevention of an ischemic should be enacted. In this case, the most appropriate drug to administer for secondary prophylaxis of a cerebral infarction is aspirin. Hypertension and lipidemia are also stroke risk factors, which should be optimized, though in this case the patient is already receiving treatment for this comorbidity. Next.
Yes. 26-year-old woman comes to the emergency department because of 3-day history of lower abdominal pain and yellow vaginal discharge. Lower abdominal pain and yellow vaginal discharge. She says her pain has increased today, that she has a fever. She has flank pain, urinary urgency, and vomiting. She becomes sexually active with a new male partner. She becomes sexually active with a new male partner 2 weeks ago. They use condom inconsistently. The patient has no history of serious illness, takes no medication. She has no known drug allergies. She is lying on a stretcher. She is lying on a stretcher and is in mild distress. BMI is 22 kg per meter square. Her temperature is 31 degrees Celsius, 101.6 degrees Fahrenheit, pulse 96 per minute, respirations are 14 per minute. Blood pressure is 124/74. Pulse oximetry on room air shows oxygen saturation is 97%. Cardiopulmonary examination shows no abnormality. There is tenderness to palpation of the lower abdomen bilaterally. There is no guarding. Bowel sounds are normal. Pelvic examination shows a friable cervix, cervical motion tenderness, and adnexal tenderness bilaterally. Which of the following is the most appropriate pharmacotherapy?
Ready?
Yes.
So cephalic doxycycline, chlamydia, Neisseria can cause vaginitis, cervicitis, PID in women. Risk factors for PID and other STIs include adolescents, multiple sex partners, and not using barrier contact condoms. Vaginitis typically presents with mucopurulent discharge, and pruritus. Cervicitis presents with similar discharge, but also with red friable cervix and cervical motion tenderness. When infection spreads to the fallopian tube, ovaries, PID with purulent cervical discharge, uterine, and adnexal tenderness, and systemic symptoms such as fever can result. Left untreated, PID can become complicated by tubovarian or intra-abdominal abscess, presenting with focal tenderness and proton mass. Treatment of PID includes IV antibiotics such as cephalosporin and tetracycline to cover potential organisms making secretion. Next.
Yes. 72-year-old man is brought to the emergency department 25 minutes after a motor vehicle collision in which in which he was a restrained driver. He has no loss of consciousness following the collision. On arrival, he is alert, and on arrival, he is alert and is fully oriented. He reports severe abdominal pain, pulse is 110 per minute, respiration are 26 per minute, blood pressure is 130 by 70 millimeter mercury. There are large ecchymosis over the left shoulder, chest, and lower abdomen. Breath sounds are normal bilaterally. Cardiac examination shows no abnormality. Abdominal examination shows severe left upper quadrant tenderness with rebound. There is no posterior midline cervical spine tenderness. Fast ultrasound is shown. Which of the following is most likely diagnosed?
Ready?
Yes.
So splenic rupture. The spleen is the one of the most common organ damage during blunt abdominal trauma with injury patterns such as laceration and rupture. Ultrasound demonstrates the left upper quadrant of the abdomen with hypoechoic fluid in between the spleen and the left kidney, raising concern for acute blood loss, blood products in the setting of trauma. I don't know, don't say that, but okay. So any rupture can cause large amounts of blood to leak into peritoneal and retroperitoneal spaces, which can result in hemodynamic stability characterized tachycardia and severe hypotension. Patients with splenic injuries may have left upper quadrant tenderness, peritonitis from blood products irritating the peritoneum, or refer pain to the left shoulder secondary to diaphragmatic irritation. In hemodynamic stable patients, minor splenic injury may be treated non-operatively with observation and reassessment. In unstable patient, exploratory laparotomy is required for repair of the injury or splenectomy, depending on the nature and severity of spleen injury. It's not perforative viscous can present after blunt abdominal trauma with abdominal pain, distension, tenderness, peritonitis, anemia, leukocytosis, and X-ray evidence of pneumoperitoneum. Um, Peritonitis require emergency laparotomy, lavage to peritoneum, and prevent sepsis, exsanguination, and bowel necrosis. Okay. Next.
Yes. A 48-year-old man is brought to the emergency department by paramedics 30 minutes 30 minutes after he sustained a gunshot wound to the chest. He is anxious and has severe shortness of breath. His temperature is 37 degrees Celsius, pulse 122 per minute, respiration 20 per minute, blood pressure 80 by 58 millimeter, blood pressure 80 by 58 millimeter of mercury. Examination shows an open gunshot wound on the right side. Open gunshot wound on the right side of the chest. There is jugular venous distension. There is JVT, jugular venous distension. Breath sounds are decreased, and there is palpable crepitus over the right hemothorax. Peripheral pulses are weak throughout. Which of the following is the most appropriate next step in the management?
Ready?
1 minute, please.
Okay.
Okay, ready?
Yes, it is needed thoracostomy. Intention pneumothorax can be a complication of penetrating trauma and occurs when air is able to enter the pleura but is prevented from exiting. Increased amount of trapped air in the pleura compresses the lung parenchyma, creating an inability of the lung to expand, causing it to collapse. As the pneumothorax progresses and continues to increase, it can result in tracheal and mediastinal deviation away from the pneumothorax, from the affected pneumothorax. It can also result in decreased venous return to the heart, which manifests as hypotension and obstructive shock. Tension pneumothorax is characterized by absent breath sounds, hyperresonance to percussion, and as a result of increased air or blood displacement in the normal parenchyma. And in cases of acute tension pneumothorax, evacuating the accumulated air via needle decompression and aspiration permits expansion of the lung and eliminates tension of the mediastinum. Immediate needle thoracostomy or decompression is followed by tube thoracostomy, which prevents the accumulation and promotes repair of the pleural defect. It's not chest X-ray, CT scan about diagnostic imaging modalities that can disclose a traumatic pneumothorax and hemothoracic fractures. Pulmonary contusions, however, in patients who are hemodynamically unstable, management should precede diagnostic imaging. In this case, attention pneumothorax is a clinical diagnosis that should be treated prior to further diagnostic imaging. And it's not the tracheal intubation in the mechanical way will not be indicated in this patient prior to emergent tracheostomy. Intubation will increase positive pressure and air entering the pleural space, increasing the severity, blah, blah, blah. Thoracostomy must be performed. Okay, next.
A 78-year-old man is brought to the emergency department by paramedics 30 minutes after a friend found him confused and disoriented in home. The patient lives alone and appeared normal when the friend saw him 3 days ago. He has type 1 diabetes mellitus, hypercholesterolemia treated with insulin and simvastatin. His friend says the patient his friend says the patient drinks alcoholic beverage socially and has smoked one half of packets of cigarettes daily for the past 35 years. He has no known medication allergy. The patient appears drowsy but is usually aroused and follow comments. His temperature is 37.6, pulse is 118 per minute, respiration 18 per minute, blood pressure 92 by 54. Pulse oximetry on the room air shows oxygen saturation is 97% and physical examination shows decreased skin turgor, dry mucous membrane, flat neck veins, hemoglobin 15, hematocrit 46, leukocyte count 9,200, platelet count 2,000, 27,000, sodium 143, chloride 104, potassium 3.9, bicarbonate 26, calcium 11.6. Calcium is high, BUN 68, glucose is very high, and creatinine is high too. A basic metabolic panel obtained 3 months ago within the A reference ranges without the following is the most appropriate next. Ready?
1 second. Between saline or insulin. Yes. Mm, mm, one moment. Okay, ready.
Okay.
Mm, Okay, so the answer is saline, giving saline. The patient lab panel suggests severe dehydration as the primary driving aberrancy driving in his clinical picture of severe dehydration, hypotension, tachycardia, decreased skin to body, dry mucous membrane, flat neck vein. He severely increased creatinine suggests a renal kidney injury, which is caused by ineffective perfusion to the kidneys. His hyperglycemia also suggests a high serum osmolality induced by dehydration. Treatment of dehydration and perirenal AKI is with isotonic fluid. This will expand the intravascular volume and improve perfusion to the kidney. However, if the perfusion to the kidney persists to the point of ischemia, then ATN, a form of intrinsic injury, can develop. Prerenal and intrinsic kidney injury can be distinguished by fractional excretion of sodium, which is less than 1 in prerenal and more than 2 in intrinsic kidney injury. Administration of insulin is not the first best step, as the primary cause of hypoglycemia is dehydration. Administering insulin will be critical if the patient were demonstrating signs of DKA. However, he has normal serum bicar and anion gap at this time. Thus, addressing his dehydration will likely resolve the majority of hyperglycemia and should be the first step in management. Okay, next. Why was the calcium high? Anyway, okay, next.
A 36-year-old woman, a 36-year-old woman with 36-year-old woman with 15-year history of IV drug abuse. 15-year history of IV drug abuse is brought to the emergency department because of 4-day history of progressive redness and pain of her left arm. Progressive redness and pain on her left arm at the site of recent injection of heroin. His temperature is 102, pulse 110 per minute, respiration 24 per minute, 24 per minute, and blood pressure 105 by 58 millimeter mercury. Physical examination shows 10 on 10, 10 is to 10 centimeter area of erythema, warmth, tenderness of the left antecubital fossa. Multiple attempts at peripheral venous access are unsuccessful. She requires placement of central venous catheter. Which of the following is necessary to discuss with the patient in order to obtain informed consent of this procedure?
Ready?
Yes, ready.
Risk of pneumothorax associated with placement of subclavian catheter. Ensuring informed consent has been obtained is a physician duty before performing a procedure. In a non-emergent setting, informed consent fulfills the ethics principle of autonomy, which dictates that the patient should be able to make their own decision about their healthcare, including whether to accept or decline procedure. Informed consent also benefits the physician-patient relationship and encourages physicians to truly review their indications, benefits, and risks um, of the procedure, and whether alternatives could be considered. Informed consent in this case must include an explanation of the proposed procedure, alternative options, the risk and benefits of procedure um, and the risk of refusing the procedure. In this case, the informed consent should include discussion of the risk of pneumothorax associated with placement of subclavian catheter. It's not E. Informed consent necessary before any procedure occurs in a non-emergent setting. Thus, it is required in this situation. And the foregoing informed consent would be negligent in the part of the physician. Okay. Next.
Yes. A 49-year-old woman, a 49-year-old woman comes to the emergency department because of sudden onset of sudden onset of right wrist pain for 5 hours ago when she tripped, fall, and landed on her outstretched right hand. She did not sustain any other injury. She has hypothyroidism treated with levothyroxine. She has no known allergy. She does not drink alcoholic beverage, smoke cigarettes, or use illicit drugs. Vital signs are within normal limit. Examination of the right wrist shows mild diffuse swelling without gross deformity. There is tenderness over the radial aspect of the wrist, including the snap box. Active and passive range of motion is limited by pain. She is able to extend, flex, abduct, and adduct the fingers, and sensation is intact to light touch. X-ray of the wrist are shown. Which of the following is the most appropriate next step in management? Is it scaphoid fracture?
I do not.
Sorry,
I do not know. I don't. It says there is no fracture on the weight. So he said there is no fracture. I don't know.
or is it in the anatomical snap box? Okay, she is
Sounds
able
like
to extend, flex,
the finger
abduct, flexion,
is limited by pain. So does she
extend.
have the ligament issue or the bone issue?
Thinking.
Fracture
Look at
reduction.
ra- the right side of the hand X-ray. The
Okay.
lightning one. There is a marking. You got it.
This one,
Uh, no, no, this one, the right one.
that one,
Yes. Look above the
this,
highlighted area. The
this.
carpal bones. Carpal bones. Yes. Isn't it fracture? Looks like a fracture. The upper carpal
Uh,
bones.
yeah.
I
Yeah,
think so.
yeah. So you think it would be fracture reduction? Uh, okay.
Is it fracture
Okay.
reduction, or
I don't
is it like
know.
we are wet?
Okay,
Okay,
let's
let's
see.
see. Maybe fracture reduction. Let's see.
It sounds like that. So it was a ligament issue. The patient history of wrist pain overlying the
Initially,
snap
I was
box.
correct. This
And,
is scaphoid fracture.
oh, patient history of wrist pain overlying the snap box following a fall of stretch end as well as radiographic findings are consistent with scaphoid fracture. Scaphoid is at significant risk for fracture after falling on an stretch end because of its narrow and fragile central waist. Scaphoid fractures can have significant and long-lasting effects as a result of the risk of non-union and proximal osteonecrosis of the bone, which receives its vascular supply in a distal to proximal fashion. Patients with non-displaced scaphoid fracture should undergo non-displaced scaphoid fracture undergo thumb spike and splinting until union has been demonstrated by follow-up X-ray. Patient with displaced fractures, carpal instability, or delayed presentation, should be referred for surgical repair. It is not activity as tolerated prior to union of the fracture increases the patient risk for non-union and prolonged functional blah blah blah. Is not the fracture reduction is recommended for displaced scaphoid fractures, carpal instability of patients with delayed presentation. This patient X-ray are more consistent with not displaced acute scaphoid fracture. Okay, next.
Yes. Okay. A 30-year-old a 30-year-old woman is brought to the emergency department because of 1 hour history of sharp left-sided chest pain and shortness of breath. She has not had fever, cough, nausea, or vomiting. Her symptoms started while she was at rest at home. She has hypercholesterolemia but has declined pharmacotherapy for this condition. Her only current medication is a combination of OCP. She lives a sedentary lifestyle and eats food that have a high salt content. She has smoked 1 pack of cigarettes daily for 10 years. She does not use illicit drug. BMI is 32. Her temperature is 36.7. Pulse is 110 per minute. Respiration is 24 per minute. Blood pressure 160 by 70 millimeter mercury. Pulse oximetry on room air show oxygen saturation is 94%. Physical examination shows tenderness and edema of the left calf. Which of the following is the strongest predisposing risk factor of this patient's current condition?
Ready?
Cough. 1 second, please.
Okay.
Is it DVT?
She has PE.
Pulmonary embolism. Okay.
Ready?
Yes.
So it's use of oral OCPs. It's a stronger risk factor for this patient condition, which is most consistent with DVT of the lower leg with embolization to the pulmonary arteries for PE. The cause of venous thromboembolism is considered provoked if it occurs after surgery, malignancy, prolonged immobilization, but is considered unprovoked in situations where that does not appear to be an inciting factor. While this distinction can sometimes be useful in estimating the risk for subsequent venous thromboembolism, is not always useful. Regardless of the cause, all patients should receive chronic anticoagulant medications such as warfarin, heparin, and or one or ODAC. Additionally, underlying risk factors for VTA should be addressed. These patient cigarette use increase the risk of venous thromboembolism, but the use of OCP, especially in a patient who smoke, confers substantially higher for VTE. This patient should be started on anticoagulation medication, and her oral contraceptives should be stopped. Additionally, she should receive counseling on tobacco cessation. It's not a lack of exercise. It's not a risk factors for VTA, although prolonged periods of immobility, such as during international flight, may confer some increased risk. Okay, next.
Yes. A previously healthy 28-year-old woman comes to the emergency department 2 days after boiling water splashed on her feet while she was brewing beer and caused a painful red areas on Her toes. 5 minutes after the incident, a blister developed on one portion of the area. She has no other symptoms. She takes no medication. Her only allergy is to wasp stings. Her temperature is 37, pulse 60, respiration 14, blood pressure 120 by 60. Pulse oximetry on room air oxygen saturation is 100%. A photograph is shown. Which of the following is the most likely diagnosis?
Ready?
Yes.
So it is partial thickness burn. This patient physical exam findings suggest a diagnosis of second degree burn or partial thickness. Burns may be caused by heat, as in this case, electrical discharge, chemicals, radiation, or friction. And are classified by the depth. When heat is cause of the burn, the depth of injury is related to the temperature and duration of contact with the causative agent. A superficial first degree burn is characterized by dry, blanchable erythema, which is painful and takes several days to heal. A partial second degree burn demonstrates blister and redness with which may sweep serous fluid. Partial thickness burns are typically painful to temperature, air, and touch, and take 1 to 3 weeks to heal. Full thickness burn 10 degree burns may be white, gray, or black and have a leathery or charred appearance. It does not blanch with pressure, and only deep pressures cause pain. Full thickness burns do not typically heal unless surgically treated. Treatment of this partial thickness wound should include pain management with acetaminophen or NSAID, cleaning and debridement of ruptured blisters, though in an intact blister should generally not be broken, whatever. And basic dressing of the area with a layer of non-adherent gauze followed by dry gauze. Topical antibiotics should generally be employed to prevent secondary infection like sulfadiazine, silver sulfadiazine, and vancomycin. It is not a, oh, where was the other one? Wait, I had another E.
The
It's
superficial.
not Yeah, it's not super full thickness cause white, gray, or black appearance. Superficial thickness cause painful, blanchable erythema without blister. This, yeah, okay.
So, how will we differentiate superficial from the partial?
Superficial is just red, and then when you touch it, it becomes white. Like you press on it changes color.
Blanchable.
Yeah, superficial with me first is the same thing as first degree. Partial is the same thing as second degree. That's when you see the bulla, the blisters, is red, all that. And partial is, yeah, second degree. Full thickness is the same thing as third degree. That's when you see like the necrosis and all that. And that one is only painful when you press deeply. When you press deep.
Can you say it
Got it?
again?
Okay. Oh, sorry. Superficial first, same thing as first degree.
So,
The
okay,
skin is mhm. The skin is red, and when you press on the skin, it becomes white, like the blanching of the skin when you press on it. Let me see.
okay.
Region of skin when press. You know what is that, right? The blanching of the skin
Yes,
when you
yes,
press.
yes.
Yeah, uh-huh. And then second degree will be um, partial thickness. That's when you see the bulla or the blisters, like you see here, and the skin is red, and there
Yes.
is it's also painful. Yeah. And then full thickness is third degree. That's when you see necrosis, and then there is no pain until you press deep. That's when you feel the pain.
Okay,
Okay. Next.
okay. Next. A 44-year-old woman who is a firefighter. A 44-year-old woman who is a firefighter is brought to the emergency department by paramedics because of smoke inhalation. She was fighting a house fire when her personal protective equipment failed approximately 15 minutes ago. She has no history of serious illness, takes no medication. Her temperature 37, pulse 115, respiration 24, blood pressure 110 by 50, pulse oximetry while breathing oxygen via NRV mask shows oxygen saturation is 100%. Physical examination shows soot in the ear, auscultation of the neck and the lungs. Auscultation of the neck and the lungs discloses stridor on inspiration. In addition to continued oxygen administration, which of the following is most appropriate next step in the management?
Ready?
Yes,
So it's endotracheal intubation. Endotracheal intubation is the most appropriate next step in management of this patient airway in the setting of acute smoke inhalation. Smoke inhalation injury should be suspected in patient presenting with facial burns, hoarse voice, wheezing, soot in the airway, stridor, or carbonaceous sputum. The inhalation of smoke and additional chemicals in the setting of fire presents the risk of injury to the pharyngeal, laryngeal, and tracheal mucus. Resulting inflammation drives the rapid development of mucosal edema, which can cause airway irritation. Airway obstruction is an immediate life-threatening condition that must be managed at or before the time it occurs. If care is not taken immediately, maintain an unobstructed path for air to flow into the tracheobronchial tree. Rapid hypoxia, hypercapnia, and death can occur. Emergent endotracheal intubation is the most appropriate next step and should be performed immediately to prevent airway obstruction. So now A or B, cyanide inhibits the electron transport chain leading to lactic acidosis, compensatory respiratory alkalosis, hypotension, lethargy, and bradycardia. The management of cyanide includes supportive care with IV fluids and vasopressors, sodium thiosulfate, which increases the conversion of cyanide to thiocyanide for renal excretion. Amyl nitrates to induce methemoglobinemia, which binds with cyanide, prevents it from acting on the electron transport chain. And also hydroxycobalamin, which combines with cyanide to create non-toxic cyanocobalamin. This patient may require these interventions, but not prior to securing the airways. Okay. Next.
yes. Can you give me 5 minutes? I'm coming with a coffee.
Yes.
A previously healthy 23-year-old man comes to the A previously healthy 23-year-old man comes to the emergency department because of fever, muscle aches, pain of his knees, pain in the left forearm wrist, and a diffuse rash. His current temperature is 38.2 degrees Celsius, pulse 90 per minute, respiration 16 per minute, blood pressure 115 by 75 millimeter of mercury. Examination shows effusion of knees bilaterally and a diffuse rash. A photograph of one of the lesion is shown. Which of the following is most likely a causative organism?
Ready?
Okay,
Yeah, what is it? Neisseria infection with genital urinary tracts with Neisseria may lead to bacteremia and disseminated gonococcal. Disseminated gonococcal infection presents with signs and symptoms including fever, chills, septic polyarthritis, Tenosynovitis, dermatitis characterized by pustular rash. Symptoms are typically acute in onset and may follow GU infection symptoms such as dysuria, pruritus, mucopurulent, and discharge. The affected joint display redness, swelling, and warm. Arthrocentesis and synovial fluid may show gram-negative diplopia and markedly increased concentration of neutrophil. Neisseria may be isolated for genital swab or drug cultures. Treatment includes antibiotic therapy with IV ceftriaxone. Recently, treatment has been complicated by the emergence of multi-drug resistance Neisseria. Okay, let me read E. Treponema is presented spirochete of syphilis, which presents with multi-stage ovarian symptoms, including primary with the pain shankel, secondary with fever, lymphadenopathy, condylomata lata, and tertiary tables dorsalis arthritis syndrome. The rash secondary to syphilis is characterized by scaly, light brown papules. Sorry, scaly, light brown macules and patches. Okay.
Okay.
Next.
A 41-year-old man who works as a research assistant comes to the emergency department 15 minutes after pricking himself with a visibly contaminated needle left in the examination room. He was wearing gloves at that time and washed his hand with soap and water immediately afterward. He is unsure when he received his last tetanus booster. He was vaccinated for hepatitis B 2 years ago. Medical history is unremarkable. Vital signs are within normal limit. Physical examination shows a small puncture wound consistent with needle stick injury. The wound is not bleeding. The patient is concerned about transmissible disease. After a discussion of the risk and benefits, request HIV prophylaxis, which the patient should also receive. Which of the following?
Ready?
Mm, okay.
So it's tetanus booster only. Needle stick injuries are a common occupational hazard for healthcare workers. This injury puts the worker at risk for inoculation of blood-borne pathogens and subsequent infection with Hep B, Hep C, HIV. Needle stick injuries also put the injured worker at risk for tetanus infection. Following such an injury, the worker should be asked about the previous vaccination, including Hep B and tetanus, and should be counseled on the risk and benefit of HIV prophylaxis. If the patient had not received his Hep B vaccine series, he should be treated with vaccination as well as with Hep B immunoglobulin. If a patient has received the tetanus vaccine, they should receive a tetanus booster if the last dose was more than 10 years ago for a clean or minor wound, or if there was more than 5 years ago for all other wounds. If they have not received the vaccination for tetanus, they should receive the tetanus immunoglobulin only for large or dirty wounds. This patient has been vaccinated with Hep B, making Hep B immunoglobulin unnecessary. Okay, so he has already received, okay, got it, and has been vaccinated against tetanus. Did he say he has been vaccinated against tetanus? He
Yes,
said
but received. He does not know his last booster time.
since he's unsure when his last tetanus vaccine was performed, he should receive a tetanus booster.
If he didn't get anything, like then they have this type of patient has to give booster as well as the vaccination, isn't it? Like tetanus toxoid as well as TIG, isn't it?
I think I don't remember the tetanus
There
thing.
was
Just
a
like
okay. there was a
There was
box.
there was a boss. This
Yes,
yes.
when the patient got nothing, then the TT and TIG, and everywhere there is TT, like clean wound, dirty wound. On all the case there is tetanus toxoid, but only one case where there is TT and TIG, as far I remember.
Okay. So Hep B immunoglobulin is not warranted. This patient has previously vaccinated against Hep B. Treatment with amoxicillin therapy is utilized in the management of skin or soft tissue infections such as those sustained from a bite wound. As this was an overlapping wound without inoculation, oxygen capsule antibiotic therapy is not needed unless the patient develops signs and symptoms of infection. Let me see. It was tetanus
This
prophylaxis.
one, this one.
Um, so tetanus prophylaxis, three or more tetanus toxoid doses in a clean wound or minor wound, like I guess, yeah. You give the vaccine only if the last dose was more than 10 years ago. No immunoglobulin. And then if it's a dirty wound, you give the vaccine if the last dose was more than 5 years ago. No immunoglobulin. Now, if the person is uncertain and non-immunized less than 3 doses like our patient, and is a clean minor wound like our patient, you just give the vaccine, not the immunoglobulin. And if it was a very or severe wound, you give the vaccine plus the immunoglobulin. Okay. So you only give the immunoglobulin with the vaccine. You cannot give the immunoglobulin. Wait, am I saying it right? You cannot give the immunoglobulin by itself. You only give it with the vaccine. Wait,
Always you
but
give the
here they give,
tetanus toxoid vaccine.
huh?
Uh, okay, what's
Always you
your
give,
question?
yeah, I get what you're saying. I get what you're saying. You always give the vaccine and you only give the immunoglobulin when you give the vaccine, and that's when it's a dirty wound.
Dirty wound and
Then
less than 3 tetanus toxoid dose.
dirty wound, always give
The
the
worst
vaccine.
condition, like less than 3 tetanus toxoid dose, and as
Hmm.
well as the dirty wound.
Got it. Got it. Thank you. Next.
Okay, a 55-year-old man is brought to the emergency department because of one day history of subjective fever and altered mental status. He was seen in the emergency department 3 days ago because of painful joint swelling. At that time, he was presumptively diagnosed with gouty arthritis and discharged with a prescription for indomethacin. He has no history of serious illness, takes no medication. The patient is alert and confused. He is oriented to the person only. His temperature is 38.5 degrees Celsius, pulse is 116 per minute, respiration 23 per minute, blood pressure 87/54 millimeter mercury, pulse oximetry on room air shows oxygen saturation 98%. The skin is cool and calming. The left ankle is swollen. Left ankle is swollen, erythematous and warm. Movement of the ankle elicits pain. The remainder of the physical examination shows no abnormality. In addition to the jar analysis, which of the following is the most likely to predict the patient's resource? Clinical course, sorry.
Ready?
Yes,
Is lactate concentration. Ah, yeah. The third international consensus definition, septic shock defines sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection, and septic shock as a subcategory of septics characterized by a vasopressor requirement to maintain mean arterial pressure greater than 65 or a serum lactate concentration greater than 2. So sepsis is defined as needed vasopressor or high lactate. Despite resuscitation, serum lactate concentration is reflective of organ hypoperfusion and dysfunction. The measurement of serum lactate is therefore a prognostic utility for this patient with clinical presentation concerning for septic arthritis and septic shock is associated with an approximate fourfold increase in mortality compared to sepsis alone. These new criteria replace the previously adopted SIRS criteria, although SIRS criteria remain widely used in clinical practice. It is not a blood cultures. Are useful for identification of the causative bacteria and for guiding antimicrobial therapy, but are not prognostic significance. Are not of prognostic significance.
So lactate concentration is gives also prognostic
Yeah, they said they just changed it. So yeah, so to define septic, wait, whether they define septic shock and septic anxiety, you look at the lactate concentration and hypotension that is not resolved by fluid resuscitation, so you need vasopressor.
Okay. After inserting a large bore IV catheter for fluid administration, which of the following is the most appropriate initial management? A 35-year-old woman, a 35-year-old woman brought to the emergency department by ambulance after the patient called 911 to say that she had taken an overdose and that she wanted to die. When the ambulance arrived 9 minutes later, the paramedics said they found her on the sofa. She was obtuned and vomitous on her pulse 110, permanent respiration 20, permanent blood pressure 90 by 46. She was diaphoretic, was given IV naloxone. Now she is in the emergency department. Vital signs are changed. Physical examination shows no abnormalities except for obtundation. She is responsive to current medications as imipramine, atenolol. Sorry, she is responsive to deep pain only. Reflex are 4 plus and symmetric ECG shows sinus tachycardia 110 permanent prolonged corrected QT interval. Her medical record lists current medication imipramine, atenolol, oral contraceptive acetaminophen, past medical history is paroxetine, triazolam, which were discontinued 3 months ago. After inserting a large organ, which of the following is the most appropriate initial management?
Respirations are normal. No depend only on the corrected QT.
Yes,
SSRI and benzo.
SSRI and benzo.
SSRI. Prolonged corrected QT, that means the QT is prolonged or is it normal?
Maybe QT is prolonged.
Prolonged, then it's the TCA, the imipramine. So I guess we intubate because she's on. Yes.
It has not been long time, isn't it?
Yeah, I was thinking also to give charcoal for
Charcoal or
TCA.
gastric lavage.
I don't think gastric. I think I was gonna think charcoal, but it keeps saying that she's obtunded, so wouldn't the charcoal she may cause aspiration? I don't know.
So you want to intubate the patient,
Because it says she's obtunded. Obtundation means like she's not conscious, right? What does obtundation mean?
probably. Yes.
Okay, let's
Let's
check.
intubate.
Don't follow me. I'm probably wrong. I'm right. It's intubate. This patient has attempted suicide by overdose, likely with imipramine this year. Features of this year overdose include confusion, delirium, cardiac arrhythmia, hypotension, anticholinergic toxicity. This patient is obtunded and unable to protect the airway. Thus, the first step in stabilizing the patient is to intubate, even before addressing her underlying cause of her symptoms. Following intubation of this patient, further resuscitation includes the administration of sodium bicarb to treat the patient's cardiac toxicity demonstrated by prolonged corrected QT interval, and the administration of IV fluid to correct the hypotension. A dose of activated charcoal may be given to bind any remaining imipramine and may only be used if the airway is protected. The mainstay of treatment for TCA overdose is sodium bicarb to treat the associated cardiac toxicity and prevent further arrhythmia. So, a broad set of lab analysis should be sent to assess for end-organ dysfunction and congestion. It's not aortic, and administered at charcoal should not be performed prior to intubation in a patient who is unable to protect airway. In this patient, activated charcoal can be used following intubation, but not before. And it's not gastric lavage is generally contraindicated in the treatment of TCA overdose, and it can worsen the associated cardiac arrhythmia by increasing vagal tone. Gastric gastrointestinal decontamination may be performed through a single dose of activated charcoal, but only after the patient airway is intubated. Next.
Okay. A 60-year-old man in the cardiac arrest is brought to the emergency department by paramedics. Bystander initiated cardiopulmonary resuscitation within minutes of his collapse. Paramedics say his initial rhythm was pulseless electrical activity. When they arrived at the scene en route to the hospital, paramedics continued CPR and obtained a supraglottic ARA. 3 doses of epinephrine were administered. No medical history is available on arrival. CPR is continued. The fast rhythm is pulseless electrical activity. The supraglottic ARA is functioning appropriately. Auscultation of the lungs discloses coarse breath sounds bilaterally. On a brief secondary survey, AV arteriovenous graft is noted in the left arm, and he was a right-handed below knee amputation. There are no signs of trauma. Finger stick blood glucose is 312. Which of the following intervention is most likely to improve this condition? Hmm,
Ready?
wait. Okay.
So its administration of calcium chloride, cardiac arrest can be caused by a variety of conditions, including hypovolemia, hypoxia, acidosis, hypothermia, hyperkalemia, hypokalemia, overdose, cardiac tamponade, ACS. For PE, hypoglycemia, attention in this patient with evidence of upper extremity AV graft, impulsed electrical activity arrest, there is high suspicion of hyperkalemia as a cause of cardiac arrest. As a result of underlying kidney injury, patients with end-stage kidney injury requiring dialysis are prone to electrolyte abnormalities. Especially hyperkalemia. Severe hyperkalemia leads to reduced myocardial excitability, resulting in repolarization abnormalities, conduction dysfunction, heart block, and bradycardia. These abnormalities can manifest on EGD as peak T wave, PR prolongation, loss of P wave. And if severe white QR is complex bradycardia, cardiac arrest, hyperkalemia resulting in ECG changes or cardiac arrest require emergent administration of calcium gluconate or calcium chloride to induce cardiac cell membrane stabilization. Further treatment after calcium may involve insulin and glucose, beta-adrenergic agonist, or beta to shift potassium into cell. Loop diuretics to facilitate the urine excretion of potassium and sodium polystyrene sulfonate to promote binding of potassium within the lumen of the gut. For severe refractory cases, dialysis may be indicated. Third administration of atropine cholinergic inhibitor is used in the management of symptomatic bradycardia and in organophosphate poisoning. It has no role in PA, in management of PA arrest outside of these cases. And it's not intubation. While endocardial intubation can be helpful in cases of cardiac arrest to secure the airway and prevent or treat hypoxemia, the cause of this patient cardiac arrest is hyperkalemia, which will be treated emergently with calcium chloride. As well, this patient has supraglottic airway, which is functioning appropriate and will sufficiently supply oxygenation and ventilate. Okay. The tracheal intubation can be attended at a later time for definitive airway. Okay. Got it.
So this hyperkalemia happens due to this patient has ESRD, end-stage renal injury.
Yeah. Next.
And where it is written?
Right here it says that he has a arteriovenous graft is noted on the left arm right here.
Okay.
That means he's getting a dialysis. That means
Dialysis, yes, true.
next.
Yes. A 43-year-old woman comes to the emergency department because of one-day history of upper abdominal pain that radiates to the back, several episodes of vomiting. She also notes a month history of epigastric pain in the right upper quadrant, lasts between 30 minutes to 1 hour, and is triggered by eating, particularly with fatty food. These episodes subside with time and are associated with nausea but no vomiting. She has heavy menstrual bleeding treated with OCP. Vital signs are within normal limit. Vital signs vital signs are within normal limit. The abdominal examination discloses epigastric tenderness to palpation with a voluntary guarding. Which of the following lab results are most likely in this patient?
Ready?
1 minute, please.
Mm-hmm.
Is it cholecystitis or pancreatitis?
I don't know. I think it's like
She has
cholecystitis.
problem after particularly fatty food.
I think it's cholecystitis that for progressive to pancreatitis.
Okay, ready?
So it's increased serum lipase. Increased serum lipase activity is commonly seen in acute pancreatitis. Acute pancreatitis presents with a pregastric abdominal pain that adheres to the back along with nausea and emesis, often in patients with history of gallstone alcoholism, trauma, hepatitis, or pericarditis. Gallstone pancreatitis may be preceded by other signs of polylithiasis, including biliary. As seen in this patient, acute pancreatitis can be complicated by necrosis, hemorrhage, abscess, or the formation of pseudocysts. Lab evaluation often shows increased serum amylase lipase concentration. Treatment of uncomplicated acute pancreatitis is largely supportive and should be IV fluids, bowel rest, pain control. Surgical intervention may be required in some complications. Not C direct, not indirect bilirubin concentration is increased in obstruction of biliary tree. Direct bilirubin is secreted in the bicanalicular of the liver and eventually drains into the form of bile duct before entering the duodenum. Obstruction of the flow of the bile in the setting of polylithiasis or ascending cholangitis causes direct bilirubin to leak into the surrounding intestine. Next,
Yes. An otherwise healthy 25-year-old woman comes to the emergency department because of 5-day history of low-grade fever, pain, redness, swelling on an area of the left thigh. There is no history of recent trauma to the thigh. Temperature is 37 degrees Celsius, pulse 85 per minute, respiration 14 per minute, blood pressure 110/70. Physical examination shows tenderness of the left thigh. There is no fluctuation. A photograph of the left thigh is shown. No other abnormalities are noted. Which of the following is the most appropriate next?
antibiotic therapy, incision, and drainage. It's swelling. Mm, do you give antibiotic or you do incision and there is no fluctuance? Ah, antibiotic, I guess. Mm, that is incision. Next. Oh, sorry. Ready?
Yes.
Mm, empiric antibiotic. Cellulitis presents with cutaneous redness, warm in duration, often following inoculation from an injury such as abrasion. Systemic symptoms including fever, tachycardia, leukocytosis are often present. Most commonly, it is acute and results from bacterial infection of the skin. The two most common pathogens are staph and strep. Clinically, the cellulitis caused by staph is typically purulent, while the strep one is not. Treatment of uncomplicated cellulitis, as in this case, is with empiric antibiotic, which covers staph and strep, such as cefalexin. If the cellulitis demonstrates purulence, or the patient has history of MRSA infection, coverage MRSA is also warranted. Potential oral antibiotic choices for MRSA is doxycycline, TMPSMX, and rapamycin. It is not ED. Incision and draining of the affected area or detailed aspiration is not necessary in this case, given that there is no evidence of abscess or physical exam. If abscess is present, then incision and drainage. In addition to antibiotic therapy is necessary.
For abscess to be confirmed, we need fever, isn't it? Like how
Fever,
we will differentiate the cellulitis from the abscess?
I guess
You
you say fever and purulent.
okay? Fever and purulence. Okay.
Next.
A 67-year-old man is brought to the emergency department. A 67-year-old man is brought to the emergency department because of 45 minutes of chest heaviness, shortness of breath, nausea, headaches. She says he was shoveling snow when the symptoms began. He has hypertension, type 2 diabetes mellitus. Medication. Uh, his medications are lisinopril, metformin. He does not smoke cigarettes or drink alcohol on arrival. He appears anxious and moderate distress. He is pale, diaphoretic. Temperature is 37.1. Pulse is 85 per minute. Respiration 16 per minute. Blood pressure 138 by 75 millimeter of mercury. Examination on room air shows oxygen saturation 97%. The lungs are clear to auscultation. ECG shown which of the following?
Oh, sterilization. So, in yes, so one with one.
V1 2.
You say V1, V1,
V1
V1 is
2. Anteroseptal, anteroapical, anterolateral. What is
blood.
the artery?
AVL. So AVL will be already not posterior, no right, left anterior descending or left circumflex. And then we have the two is the inferior. You say AVL and which one?
If you go through V1 2 3 4 5 6, like anteroseptal, anteroapical, anterolateral, you have heard this thing from first aid.
Mm-mm.
So V1 to anteroseptal is LAD, anteroapical is LAD L6, anterolateral is L6 probably. So probably LAD fits here. You got my point. Okay, what I am talking about. I will share my screen and make you see. Okay. You are thinking about LCX.
Oh, you were, oh, no, maybe not. You were thinking about LAD.
Yes,
Okay. So LAD will supply, wow, LTX will supply what? LTX is
look
the,
here.
oh,
If
let
you
me see.
see this thing, then you
I
will.
don't,
Yes, now,
I don't see your screen. No,
now
no.
I have shared the
Now,
screen. Okay. Look here. I am talking about this. V12 anteroseptal, that is LAD. V34
mhm.
anteroseptal, sorry, anteroapical. This is distal LAD. V56 anterolateral LED or L6. Look here,
Mhm.
leads with ST segment elevation or Q waves. Now look
Mhm.
at the ECG. Now look
Mhm.
at this ECG. This one, sorry, with my magnifier. Okay, can you see with magnifier?
Mhm.
So V1, V2 is ST segment elevation, isn't it?
Yeah, so V1, V2,
2
yeah, okay.
is anteroseptal is LED. 3, look at 3, V3 ST segment elevation. Look at V4 ST segment elevation. Even V5 also ST segment elevation and V6 also. So every ST segment elevation from V1 to V6 comes with the LED. Look here. And the LCX comes personally with one AVL ST elevation, but on that ECG, one AVL got T inversion, ST depression and T inversion. Look, one and AVL. There is T inversion, not ST elevation. You got my point.
Oh, okay, okay.
And
Can you
inferior,
send me,
sorry,
go ahead. Oh, I was saying, can you send me that one? But
yes,
okay.
obviously,
Mm-hmm.
I can give you now. Okay, okay, I'm sending this.
Mm-hmm.
So you got the point.
Yeah, I got it.
So that's how you can figure it out. If you look at other things, like try to match up with the clue, then you will not happy.
Okay. So the answer is LAT.
Okay,
The patient
you
is
found the,
present. Mhm.
I have sent it in the, sorry, in the
In
chat
the
box.
chat.
Yes.
Let me see. Let me see. I got it. Let's see. Yeah, I got it.
Okay,
Thank you. Patient is presented with signs of ACS, angina, nausea, dyspnea, anxiety, diaphoresis that began during exertion. Additionally, the ECG shows ST elevation in the precordial leads V2 to V6. Polarization and repolarization abnormalities along this vector correspond with injury to the myocardial territory supplied by the left anterior descending coronary artery, which includes the anterior portion of the IV interventricular septum, the anterior left ventricle, and the anterolateral papillary muscle. The left anterior descending artery branches from the left main coronary artery and perfuses a significant portion of the myocardium. Monocclusive atherosclerotic or thromboembolic lesion of this vessel results in transmural myocardial infarction is likely underlying presentation. Treatment requires use of antiplatelets, aspirin, clopidogrel, heparin, pain control, revascularization, angioplasty, thrombolysis, or coronary artery bypass graft. Potential complication, papillary muscle rupture with subsequent mitral regurg, dysarrhythmia, cardiogenic shock, pulmonary edema, ventricular warfare, post-infarction, pericarditis. How do you see the ST elevation on this
sorry.
one? I'm
Okay,
saying on this
yes,
is
yes.
this one, this
This
bump?
one, I am telling you, I am sharing my screen again.
Okay.
I think for limb lead, it for maybe one small square, and for chest lead, maybe two small square. Isn't it for ST elevation to consider? As far I remember. Okay, this one is very short. That's why it is tough to look at. Okay, this is like P. Can you see my drawing?
Uh-huh.
Very
Uh-huh.
bad. This is Q. This one is R. This one is R. And this one, okay, I'm changing the color. So this one is S.
Mm-hmm.
You got it? This one is R and
Mm-hmm.
this one is S. So this
Mm-hmm.
is R part, this is S part. Now look at here. So this one is S. So T would be just like there would be like normally. You got it? That Q R S. Then slightly elevation T. Then here this is T. Okay. Look at here. P
Okay.
Q R. Sorry. P. First downward deflection is Q. Then R. Then S. Then T. You got it? Look at
Yeah.
here. This would be kind of flat. It should not go upwards like an slope. But in
Okay.
here, it makes a slope. That's why it is a elevation. Look at here. There is no slope.
Okay.
Just differentiate from V1 to V2. This is
Uh-huh.
this is S, and then the flat, and then this is T wave. But look
Oh,
at
so
here. Sorry.
so this one don't have an R.
No, this one
Okay.
don't have R.
Okay, got it.
Okay.
Got it. Got it. Thank you.
Next.
Okay.
If you get this PDF in a full free version, use it. Foxit PDF reader. You got
Mm-hmm.
it? If you
Mm-hmm.
get the full free version, not the paid version, my,
Mm.
everything in my computer, most of them is hacked. That's why I use this version. Like the paid version is very costly, but this
Yeah.
is the hacked version. That's why I can use everything, like the magnifier and everything. Okay, leave it. Once upon a time, I want to be a. Okay, don't say
A
that.
hacker. You want
Yes.
to be what? A hacker. Okay.
Okay. A 73-year-old man is not totally that like want to be a specialist in computer. Okay. A seven
Oh.
a 73-year-old man is brought to the emergency department by paramedics because of a 4-day history of progressive shortness of breath. Paramedics report that during transport, the patient was awake and alert. Pulse oximetry on room air showed oxygen saturation 88%. Oxygen saturation is 88%. Mm, and 4-liter oxygen via nasal cannula was initiated. Diffuse wheezes were heard bilaterally, and inhaled albuterol and ipratropium were administered. Medical history includes congestive heart failure, chronic obstructive pulmonary disease, and type 2 uh, diabetes mellitus. Current medication are furosemide, albuterol, insulin glyburide, and tramadol. He has smoked 2 packs of cigarette daily for 50 years. On arrival, he is slow to respond and sleepy, but easily aroused. His temperature is 36.9, pulse is 112 per minute, respiration is 12 per minute, blood pressure is 167 by 90 millimeter of mercury. Pulse oximetry now shows an oxygen saturation is 95%. Pupils are normal and reactive. Severe inspiratory and expiratory wheezes are heard on auscultation. Which of the following is the most likely cause of this patient's change in mental status during transport to the hospital?
Ready?
1 second. Okay.
So it is, what is that thing? Circulating endo, what? Wait, I'm in question 39. It says the answer is correct answer B, hypercarbia. Most likely explains this patient's change in mental status during transport to the hospital. Patients with severe chronic COPD commonly develop hypercarbia at baseline as a result of obstructive disease, but acute exacerbation, which are frequently the result of respiratory tract infection, can lead to acute worsening of the underlying obstruction. Patients present with increased dyspnea and wheezing, which represents tubular effort to the constricted bronchial tree. Concurrent cough and sputum production are also common. When the underlying obstruction is exacerbated by a trigger, patients develop profound air trapping and are less capable of expelling carbon dioxide. On arterial blood gas analysis, this manifests as an increased partial pressure of carbon dioxide. Severe hypercardia can lead to lethargy and mental status changes. For this reason, all patients with COPD exacerbation and altered mental status should be evaluated for the presence of hypercardia. Treatment involves the administration of bronchodilators, medication, steroids, MPPV, sorry. Occasionally, intubation is required if the patient becomes obtunded. Additionally, patients with COPD tend to have lower oxygen saturation at baseline as a result of their underlying pulmonary parenchymal disease. During COPD exacerbations, the goal oxygen saturation should target like 88 to 92. Historically, administration of supplementary oxygen to raise the saturation beyond this amount has been postulated to blunt respiratory drive, though actual evidence for this is limited. It's probably instead that the administration of supplemental oxygen worsens ventilation perfusion mismatch in this patient population. It is not hypoxemia. It's incorrect. It's common for patients with COPD to have low oxygen saturation at baseline. This patient oxygen saturation of 88 corresponds to partial pressure of oxygen of approximately 55. While this is lower than normal, it will be unlikely to cause altered mental status. It may actually be a baseline around the clock saturation for patients with COPD. Medication adverse effect is incorrect. Insulin and glyburide can cause hypoglycemia, but this patient will likely have demonstrated altered mental status at the time when the paramedic arrived. Tramadol can also cause lethargy, but symptoms would have been expected at the scene. Next.
Yes.
Oh, wait, that's the same thing. 39, 40. Oh, okay.
After administration of inhaled albuterol and ipratropium, the patient conditions has not improved. Physical findings are unchanged. Which of the following is the most appropriate next step?
Ready?
Yes.
Mhm. So it's initiate MPPV. Initiate MPPV is the most appropriate immediate step. Patients with acute exacerbation of COPD often develop a PECAP, so increased CO2, the consequence of bronchial constriction and poor ventilation. Initial treatment should focus on dilating the airways with the use of beta agonists medications such as albuterol. Additionally, antimuscarinic agents such as ipatoprine can be given along with oral steroids or IV steroids. In some instances, hypercarbia, so increased CO2, persists despite intervention. This patient benefits from NIPPV. This type of ventilation includes continuous positive airway pressure like CPAP or BiPAP. In bilevel modes, both the inspiratory and expiratory pressure can set to augment patient's ventilation. The expiratory pressure has to maintain patency of the airway during expiration in an attempt to combat the collapse of the airway that is common to patients with COPD. This type of assisted ventilation frequently results in resolution of this increased CO2, but only patients who are awake enough to cooperate with the machine are candidates for its use. It's not, what did I pick? Oh, E. Administrate switch to nasal cannula from nasal cannula to non-repeater mask is incorrect. A non-repeater mask delivers more oxygen than a nasal cannula. This will not correct the underlying obstructive ventilation problem, which is more amenable to prevent to with treatment with NIPPV. Okay. Can we take a quick break? I want to
Yes,
do my
yes,
breakfast.
obviously.
Okay. Thank you.
A 45-year-old man is brought to the emergency. A 45-year-old man is brought to the emergency department because of multiple episodes of vomiting during the past 30 minutes. The first episode was non-bloody, but all subsequent episodes have been a mixture of bright red blood and a coffee ground like substance. He has no family history. He has no history of similar symptoms. He has history of major depressive disorder treated with fluoxetine. He drinks 12 beers daily. On arrival, he is alert, fully oriented. He is retching actively in the bed. His skin is pale and diuretic. Temperature is 37.3 degrees Celsius. Pulse 145 per minute. Respiration 22 per minute. Blood pressure 80 by 35 millimeter of mercury. Pulse oximeter on room air show oxygen saturation 96%. Abdominal examination shows distension of the positive fluid web. Abdominal examination shows distension of positive fluid web. There is no tenderness, guarding, or rebound. Rectal examination shows brown stool. Test of the stool for occult blood is negative. Two large bore IV catheters are inserted. 0.9% so saline 2 liter is administered. His pulse is 140 per minute. Blood pressure is 90 by 60. Which of the following is the most likely cause?
Ready?
Yes,
It's varices. Secondary to cirrhosis, the most likely cause of this patient bleeding. Major causes of upper GI bleeding include peptic ulcer, Mallory Westier, gastritis, Diolaf lesion, whatever. Perfusiosis can cause hemorrhage as dramatic as potentially catastrophic as rupture esophageal varices. This patient has evidence of decompensated cirrhosis with a distended abdomen and fluid waving. Indicating ascites, both ascites and esophageal varices are consequent of portal venous hypertension, which occurs as a result of obstruction of flow through the sinusoid within the liver. All patients with bleeding esophageal varices should have two large bore catheters inserted for the administration of acetonic crystalloids and pancreatic blood cells. This patient continues to have signs of hemorrhagic shock despite adequate food resuscitation. Thus, he should receive pancreatic blood cells. Additionally, patients with bleeding varices should receive IV antibiotics such as ceftriaxone and octreotide and PPI. Initial care should focus on stabilizing the patient to facilitate operendoscopy, at which point varices can be ligated for definite self-control and to prevent further bleeding. It's not C. Esophageal rupture presents with severe retrosternal pain and signs of sepsis, not GI bleeding. Retrosternal and signs of it. Esophageal rupture may occur as a result of prior instrumentation during endoscopy or violent retching. Next.
Yes, a 32-year-old woman is brought to the emergency department 2 hours after a drug overdose. Empty bottles of diazepam and acetaminophen with codeine were found in her room. She is somnolent. Examination shows decreased gag reflex and decreased deep tendon reflex bilaterally. Which of the following is the most effective method to prevent pulmonary complication in this patient?
Ready?
1 minute. Okay.
Yes, endotracheal intubation. Initial exam of a patient in distress should include an evaluation of the airway, breathing, circulation. The most common reasons for urgent endotracheal intubation are inability to protect the airway, apnea, hypoxemia, hypercarbia, although other reasons also exist. These include dynamic airway changes in the setting of neck trauma, hematoma, inhalation injury, and anaphylaxis and angioedema. This patient is lethargic with absent protective airway reflex, gag reflex, which profile an increasing of aspiration. Aspiration occurs when gastric or pharyngeal um, enter the airway, which can lead to pneumonitis or pneumonia. Aspiration pneumonia presents with cough, shortness of breath, paralytic chest pain, fever, abdominal breath sounds. Chest X-ray will exhibit patchy infiltrate, most commonly in the right lower lobe if the patient was upright while the aspiration occurred, or the posterior gravity-dependent portion of the lobe if a patient was supine. Therefore, in order to prevent this patient from aspirating and developing consequent aspiration pneumonia, rapid sequence endotracheal intubation should occur. Next.
Yes. A 38-year-old woman is brought to the emergency department by her husband after she had a syncopal episode at home 30 minutes ago. On arrival, the patient is doubled over in pain. She says that she had abdominal pain about an hour before she fainted, that it has been continuous for the past 30 minutes. She says that she has never been pregnant and has been healthy and is not taking any medications. Her temperature is 37.3 degrees Celsius, pulse is 120 per minute, respiration is 22 per minute, blood pressure is 80 by 40 millimeter of mercury. Which of the following is the most appropriate next step?
Ready?
1 minute. Okay.
Is IV fluid resuscitation with 0.9 saline. IV fluid resuscitation most appropriate first step for patients with hypotension who recently suffered a syncopal episode. The cause of syncope is variable and may occur as a result of reflex or neural mediated cause, ventricular arrhythmia, orthostasis. While syncope is often benign, it is important to obtain ECG to evaluate for cardiac causes of syncope, such as arrhythmia or structural heart disease. But this should only be done after appropriate fluid resuscitation has established. started. In patients with hypotension such as this one, attempt should be made to restore intravascular volume with the IV administration of acetonic crystalloids. While this patient's underlying condition causing abdominal remains undifferentiated, she should receive pre-resuscitation while undergoing workup for abdominal pain. Additional diagnostic studies should follow the correction of her vital signs abnormalities. Not E. During pregnancy tests and ultrasound may both be necessary to further differentiate the cause of this patient pain, but they should occur after appropriate pre-resuscitation. Next.
A 58-year-old man is brought to the emergency department by paramedics because of 2 hour history of palpitation, shortness of breath. His symptoms began suddenly while he was making breakfast and are associated with lightheadedness. During the past 15 minutes, he had become diaphoretic and feels more lightheaded. Had he has not had fever, chest pain, cough. He has hypertension, type 2 diabetes, mellitus, coronary artery disease with prior stenting and arterial fibrillation. He takes metoprolol, lisinopril, metformin, aspirin, clopidogrel. He has no allergies. He does not drink alcoholic beverage, smoke cigarette, use illicit drugs. Honorable patient appears diaphoretic and pale. His temperature is 37.1 degrees Celsius. Pulse is 158 per minute. Pulse is 158 per minute. Irregular. Respiration is, sorry, blood pressure is 80 by 46. Blood pressure is 82 by 46. Pulse oximeter on room. Your oxygen saturation is 95%. Lungs are clear to auscultation. There is no jugular venous distension. The remainder of the examination discloses no abnormality. ECG is shown. Which of the following is the most appropriate next step?
Mm, already taking metoprolol.
Sorry,
No, so I was saying sorry, he's already taking metoprolol. Metoprolol.
patient is hemodynamically unstable, isn't it?
Oh, so he's unstable.
Yes, BP is 80 by 46.
Okay, so I guess synchronized cardioversion, I guess.
Not really.
Oh, don't synchronize.
Synchronization can cannot happen in AFib because in AFib there is, okay, synchronization can happen. Sorry,
Okay,
like cardioversion should be done.
okay. Ready?
Yes.
In synchronized cadaver, ECG shows irregular narrow complex arrhythmia lacking P waves AFib. Heart failure and as AFib share many common risk factors and each predisposes to the development of the other. AFib with rapid ventricular response more than 100 can result in reduced stroke volume and decreased cardiac output leading to symptomatic heart failure, potentially hypotension, and hemodynamic instability in severe cases. This patient is presenting with hemodynamically unstable AFib with hypotension, tachycardia. The most appropriate initial treatment is synchronized cardioversion to quickly correct the arrhythmia and restore adequate cardiac output. It's not metoprolol, diltiazem are appropriate therapy options for hemodynamically stable patients presenting with AFib with rapid ventricular response. Rate control with diltiazem or metoprolol is recommended for most patients as opposed to rhythm control with amiodarone because of similar efficacy and fewer. Synchronized catheterization is more appropriate because the patient is unstable. Okay. Next.
Can you read the option B?
Yes. Defibrillation is effective at terminating AFib with rapid ventricular response but carries a risk for inducing a ventricular arrhythmia. Synchronous calibration is preferred to avoid this risk.
Okay. 44-year-old woman comes to the emergency department 2 hours after sudden onset epigastric pain. The patient says the pain radiates to her back and improves when she leans forward. She rates the pain 9 on a 10 scale. She has vomited twice, still feels nauseated. She has obesity and cholelithiasis. She does not take any medication and has no known drug allergies. She drinks 2 glasses of wine on the weekends and does not smoke cigarette or illicit drugs. BMI is 29 kg per meter square. She appears uncomfortable. Her temperature is 99.2 degree Fahrenheit. Pulse is 96 per minute. Respirations are 18 per minute. Blood pressure is 138 by 87 millimeter of mercury. Pulse oximetry on room air shows oxygen saturation is 98%. Physical examination discloses tenderness to palpation of the epigastrium. The remainder of the examination shows no abnormality. Lab studies show leukocyte count 14,000, serum ALT 184, AST is 126, LP is 210, lipase is 368. Which of the following is the most appropriate pharmacotherapy?
Ready?
Is it antibiotic or painkiller?
I don't know. Want me
I-
to?
Isn't it pancreatitis?
Yeah, I was confused between the two also. It's between ascending cholangitis or pancreatitis. I guess, yeah, I guess it will be pancreatitis. Kind of.
Okay.
Ready?
Yes.
Okay, so it is hydromorphone. Opiate analgesics, including hydromorphone, are the cornerstone of acute pancreatitis pain management. Acute pancreatitis presents with epigastric abdominal pain that radiates to the back along with nausea and emesis, often in patients with history of cholelithiasis, cholestal, blah, blah. Acute pancreatitis can be complicated by necrosis or blah. Lab evaluation often shows increased amylase lipase treatment, supportive and include IV fluids, bowel rest, and pain control. Associated pain from acute is typically severe and often requires the use of opioid analgesic. It's not if piperacillin tiobartam postpartum antibiotic is not warranted initially in the management of acute pancreatitis. Acute pancreatitis is caused by severe inflammation rather than infection, and antibiotics are only necessary if there is secondary infection of pancreatic necrosis. Okay. Next.
Yes. A 57-year-old man is brought to the emergency department by his son 30 minutes after he had tonic-clonic seizure that lasted 1 minute. The patient is disheveled and has difficulty giving a coherent history. The son reports that his father has a 20-year history of alcoholism, 20-year history of alcoholism and typically consumed 16 to 32 hours of vodka daily. The patient's temperature is 37.8 degrees Celsius, pulse is 110 per minute, respirations are 20 per minute, and blood pressure is 150 by 70 millimeter of mercury. The is slightly jaundiced. Skin is slightly jaundiced, and there are spider angioma over the chest. Abdominal examination shows ascites. The abdominal examination shows ascites. The liver ridge is palpated 5 centimeter below the right costal margin. Neurologic examination shows diffuse. Neurologic examination shows diffuse symmetrical tremor. No asterixis is noted. His mini-mental state examination can score cannot be quantified because he does not cooperate. In addition to IV fluid, multivitamins, folic acid, vitamin B1 administration of which of the following is the most appropriate next step in the management?
Ready?
Yes.
Okay, so it's diazepam. Alcohol use disorder causes changes in the expression of CNS GABA and glutamate receptor subunit, leading to sympathetic hyperactivity in the setting of alcohol withdrawal. Initially, this hyperexcitability results in tremors, anxiety, diaphoresis, hypertension, tachycardia, nausea. Within hours of the last drink, alcoholic hallucinosis and seizures can occur. Delirium tremors, the most common concerning and life-threatening complication occur involve severe confusion, disorientation, fluctuations in consciousness, agitation, vigil, and autonomic stabilities, like fluctuations in heart rate, blood pressure, and hyperthermia. As a result of their activating effect on GABA, benzos such as diazepam are effective in reducing the psychomotor hyperactivity associated with alcohol withdrawal. Long-acting benzos are preferred because they reduce the risk for recurrent seizures. Many centers employ a symptom-based approach to treatment of alcohol. It's not, I would say, I guess, atenolol. Should not be used to treat alcohol as its efficacy for reducing seizures is less well characterized than benzo. May also mask the signs of hemodynamic stability that are associated with delirium and is not anticonvulsant, such as phenytoin, is not typically necessary for seizure associated with alcohol withdrawal. It does not address the underlying cause of seizure. Benzos and barbiturates in escalation are most appropriate. Next,
Yes. Isn't it VT? Okay.
pick from the thing.
Sorry.
Give your answer from
Isn't
the
it? I have two differential. One is VT, another is polymorphic, like
from this one.
Torsat, Torsat T pointies.
So what will be the answer
Calcium gluconate.
for this one for this for
V,
Torsat?
I think that it's Torsat, isn't it?
Oh, so it's two deep. Okay, okay. I thought we were looking at this one. Okay, I thought Torsat is the one we're looking at.
Is it calcium gluconate or magnesium?
The treatment for what?
Torsats.
I thought it was magnesium.
Isn't it Torsats?
Yeah.
Okay. Let's see the answer.
Oh,
Don't.
you want to second?
Oh,
Oh, yeah, it's
okay.
magnesium. ECG shows Torsat's the point of dangerous
Like
polymorphic.
in Torsats, initially the upper one actually symbolize the ventricular tachycardia. The
Oh, really?
the the this one,
Then,
yes, yes.
yeah, yeah, yeah.
There is fusion bit, there is capture bit, and there
So
is
what would you give
polymorphism.
for that?
Sorry.
What would you give for that? Then?
In VT,
So, but I thought ventricular tachycardia is defibrillation straight.
there is two. Like if it is polymorphic, there is there is a flow chart. Actually, I forgot. Okay, let's
Okay,
read.
okay. ECG shows Torsades the point dangerous polymorphic ventricular tachycardia characterized by sinusoidal pattern with cyclic variation. Now, episodes are typically brief and result spontaneous, but patients are at risk of progressing to VFib. Hemodynamic collapse and death. Patients with prolonged QT interval, which may be familiar or acquired such a blah, blah, are susceptible to developing towards the point. Medications that are associated with torsades de point include class 1A and 3 antiarrhythmic agent, macrolide, fluoroquinolones, antibiotics, methadone, antipsychotic, antidepressants, antiemetic, diuretics such as furosemide. For magnesemia, hypokalemia, hypocalcemia also increase the risk. EQRST, okay. The patient presentation typically involves palpitation, syncope, lightheadedness, tachycardia, and pallor. Immediate treatment requires IV magnesium, which inhibits calcium influx into the myocardial cell and suppresses early after depolarization to interrupt the arrhythmia. Any potential potassium, any potential QT prolongation medication should be stopped, and consultation with cardiologists is recommended to determine if long-term pharmacotherapy or implantable cardiac device is needed. Hemodynamically unstable patients generally require cardioversion, which may not be possible given the polymorphic nature of the arrhythmia, or defibrillation. Next.
Okay. Okay, next.
Hmm.
A 60,
Can you tell from the strip, is it A flutter or VTEC?
if a flutter to happen, then other wave should be present. It probably
Okay.
it is ventricular tachycardia, or it
Okay.
is ventricular fibrillation.
Oh, tachycardia, fibrillation, tachycardia.
The
Okay,
the
either
next
way.
the next VTech ultimately goes to VFib.
Okay, so either way, it's the same treatment for both. Do you want to pick or do you want to read the question?
No, I want to pick.
Okay, wait. Let me see if the patient is unstable.
Like in here, there is irregular, chaotic type of rhythm, isn't it?
Yeah.
There is
o-
no there is absence of organized QRS complex.
Okay. Pick. Ready?
Yes.
So is the fibrillation. This patient is presenting with cardiac arrest and CPR has been initiated appropriately. The most important factors that improve the chance of survival for cardiac arrest are early activation of the emergency response system. This patient was already present in the emergency department. Immediate initiation of high quality chest compression, early defibrillation, shockable rhythms, and early initiation of advanced cardiac life support. The rhythm strip shows ventricular fibrillation, and the most appropriate next step is defibrillation. Defibrillation should be administered to patients presenting without a pulse um, that exhibit either VFib or VTEC on the rhythm strip. Uh, Pulses, electrical activity, and asystole do not respond to VFib. Delay initiating without a pulse. Okay. Okay. Delay initiating chest compression and administering the first defibrillation shock in the setting of shock arrhythmia associated with a decreased likelihood of achieving return to spontaneous circulation. It's not E. Intubation and mechanical ventilation are recommended in ACLS protocol for securing the airway and ensuring adequate oxygenation and ventilation, maintaining perfusion pressure and attempting to restore cardiac function. Uh, Function take priority over advanced airway management in CPR. Basic airway and breathing management include back valve ventilation and oxygenation should be prioritized. So when there is issues with the heart, we check the heart rate before the airway. I think that's what they're saying.
Yes.
Okay. Next.
Yes. A 61-year-old African American man with previously stable angina pectoris comes to the emergency department because of 2-day history of worsening chest pain. The pain occurs at rest with minimal exertion. He rates the pain as an 8 on a 10 scale. Nitroglycerin has provided only moderate relief. He has not had diaphoresis, nausea, or dyspnea. He has coronary artery disease, type 2 diabetes, mellitus, hypertension. He has no history of liver disease or bleeding problem. In addition to nitroglycerin and medication include glyburide, valsartan, hydrochlorothiazide. He is 178 centimeter tall and weight is 85 kg. BMI is 27 kg per meter square. His temperature is 37.3 degrees Celsius, pulse 87 per minute, respiration 18 per minute, blood pressure 130 by 68 millimeter of mercury, pulse oximetry on room air show oxygen saturation 93%. Physical examination discloses no abnormality. The chest X-ray shows minimal cardiomegaly, and ECG shows T-wave inversion in the anterior lead not seen on previous ECG. Serum cardiac enzyme concentration are within the reference range. The patient is given 3 liters of oxygen via nasal cannula. Morphine is administered. The patient is pain-free. In addition to administration of the aspirin, which of the following is the most appropriate next step?
Ready?
1 second.
Okay.
Okay, ready.
Is administration of heparin. Administration of most of heparin. This 61-year-old patient with history of stable angina, benign onset, chest pain at rest. Um, yeah. Anti-weight inversion anterior most likely as unstable angina. There are three main categories of ACS: unstable angina, and STEMI and STEMI. STEMI present with chest pain, ST elevation on ECG and pulse, and troponin is elevated. Treatment is with thrombolytics and immediate cardiac catheterization. UN and NSTEMI are similar condition and present with ECG changes such as T-wave inversion and ST depressions, okay, and chest pain, but are differentiated by the presence in STEMI or absence of cardiac biomarkers. So I guess NSTEMI has increased troponin and UA doesn't. Regardless of UA and STEMI are treated similarly with dual antiplatelet therapy and full dose anticoagulation. Appropriated anticoagulation choices either on fractionation, heparin on fractionated or low molecular weight. Patients are identically risk stratified using various models to determine the urgency of cardiac catheterization. Most will undergo catheterization in like a day. It is not the where is a referral to cardiac surgery is not appropriate at this time. This patient should first be treated with anticoagulants and antipsychotics, followed by cardiac catheterization in patients with multi-vessel coronary artery disease, not amenable by cardiac stent placement. Coronary artery bypass surgery is an alternative option. Next,
Yes. Okay, look at the ECG.
okay. See.
What is your diagnosis?
Let me see. So, the elevation in V1, V2, V3, V4. I guess V5. So LAD. So STEMI? Oh no, I'm wrong. Hello?
Yes, yes, yes.
Oh, I'm right. STEMI.
Initially, I pulse is irregular, isn't it?
Oh, wait.
Atrial fibrillation.
Irregular. Where is it? Where do you see? Oh, irregular. Okay, okay. So is a
Where
fib.
you have seen the STEMI?
Never mind. I thought it was this. Don't worry. Don't worry. Never mind. It's a fib.
AFib
Because
and
we are,
patient is hemodynamically unstable,
is hemodynamically
isn't it?
unstable. So you think we go straight to cardioversion?
I think
I
so.
mean, it's either cardioversion of diltiazem, but I guess I
No, no,
prefer.
diltiazem for like stable patient. Patient is hemodynamically unstable. I actually go through the hemodynamic stability, instability, instability via the BP. This is the
Yeah.
primary marker.
Okay.
In clinically also you can just go through the blood pressure. If you feel that pulse is irregular and hemodynamic unstable, go for the treatment. Go for the kill. Okay. What is your answer?
So you think it's electrical cardioversion?
Yes.
Okay, 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 okay. So you don't think it's saline?
No. Saline for inferior MI.
Saline for inferior. Okay. So let's check. Yes, it's cardioversion. The ECG shows an irregular AFib. Heart failure and AFib, we know. AFib with rapid ventricular response can result in blah, blah, blah. In reduced stroke volume and decreased cardiac output leading to symptomatic heart failure and potential hypertension. And hemodynamic instability in severe cases. This patient is presenting with hemodynamic unstable AFib with hypotension tachycardia. Most appropriate initial step is synchronized cardioversion to create correct pattern. It's not administration of saline is not appropriate at this time and may worsen the patient tachyarrhythmia induced heart failure as he has evidence of pulmonary edema or physical exam with pulmonary factors. Oh, I didn't read that part. The bacillus factors.
If
Okay.
you read that part, you will be distracted
Yeah.
because
Uh,
if you think that it is basilar crackles, then you will think about the heart failure, isn't it?
no, because I still see the irregular rhythm. But at least I would know that I guess not give fluid because he has fluid in the heart.
Crackles. Oh, oh, yes, that's true.
Okay.
Okay, we are done. From tomorrow, we'll start biostat, isn't it?
Yes, we are finally done
Done.
with CMS. We've done like 50 CMS. At this point, if we don't